Okay, is the sound better? Better na? Is the sound better?
Opo.
Okay, sige. Okay, so now, as you know, one of the more common causes of diseases in the gallbladder is gallstones. And it's the most common, and therefore that is where the label of the discussion will be. So, will be gallstones, cholelithiasis, cole. Can you see my point? Cole is galls, lithiasis is stones, gallstones. Okay, so we'll start with the pathogenesis that is related to it, and of course, the risk factors and the mechanism, and lastly, how to treat these patients. So, okay, so there are different types of gallstones, and I think that's very evident because not all gallstones are the same. And the factor is that there are cholesterol stones. In 80% of them are due to cholesterol monohydrate. 50 to 90% has combination with calcium. Because it's cholesterol, the color is yellow, sometimes green because of calcium. It may be solitary or multiple, radiolucent on X-ray, and predominantly in Western, but not anymore because it's commonly found in the Asia Pacific region also because we have a lot of fast food chains. Then that you can also see cholesterol stones predominantly in Asian countries. Now, the concept there is nucleation, there is supersaturation. So the bile is supersaturated excess with cholesterol over the diet now. Whether it is underproduction, so much diet that you do, or decrease in the excretion of the cholesterol in the body, this all points to a bile supersaturation. Nucleation, then is motility defects. Does not move. Anything that does not move is actually there for a long time, becomes hard and difficult to remove. The concept is very similar to you cook one with oil. Sometimes you forget to wash the pan, and the area that is left, that is unwashed, that has a lot of cholesterol, through time hardens. That's a so. Now, the other which is commonly seen in the area of the Asia Pacific region is calcium bilirubinate. Calcium, that's why it's black. Small, irregular, radio opaque because it's calcium content, and associated with other conditions like hemolysis, cirrhosis, or patients who actually are on chronic TPN or parenteral nutrition. They actually come, they don't, there's no infection, it comes from a sterile body. And because of its hemolysis, the unconjugated bilirubin is higher, and it actually precipitates with calcium. The last on the left right side of your screen is brown pigment stones. There is a lot of more than about 5%. It is actually the one common in Asian countries before and even now. It is found in the intrahepatic ducts because it is actually associated with biliary infection or stasis or stagnation of the bile. Here we have beta-glucanase, which deconjugates bilirubin and then precipitates with calcium and ends up in the, because of the excess production, ends up now in the gallbladder. Having said this, this is how it works. You have now a cholesterol, the bile supersaturation, nucleation, and gastric motility. These are the three concepts that are related to production of gallstones. So first, you have a bile that contains cholesterol, bile this the normal cholesterol is actually solubilized into micelles. And you produce a litogenic bile, which is high in cholesterol secretion and low in bile salts. So when you have a lot of high cholesterol secretion, this becomes bile sludge or supersaturation index, which is more than one. You then develop now gallstones or cholesterol stones. So in essence, you have the reductase activity, which increase hepatic cholesterol, but decrease in bile acid pool, because most of the time, this is the one that has a lot cholesterol and bile salts that are less. Supersaturation, as I mentioned, does not spontaneously crystallize. And you need nucleation to crystallize it. So you have pro-nucleating factors, the mucin, the immunoglobulins, and fibronectin, producing now a supersaturated diet in nucleates. So it forms um, sort of a sludge. No? And this nucleation time is where, if it stays nucleated, if it stays solid, you then have a cholesterol stone in 2 to 3 days. And lastly, of course, if the gallstones is not moving, it stays in one place, then it then produces now bile stasis or crystal retention. Now, one of the factors that inhibits patients with gastric motility is cholecystokinin. So anything you eat, your gallbladder contracts because of cholecystokinin. So there is decreased cholecystokinin response. Maybe the amount is normal, but the response to cholecystokinin is decreased, and you have an incomplete gallbladder contractions. This then produces a crystal, a stone, and through time becomes bigger and bigger, and you have now a prolonged fasting or a patient with gout. When you decrease cholesterol stimulation, is due to pregnancy, TPN, parenteral nutrition, and prolonged fasting. So when you don't fast, there's no movement of the gallstones, or the gallbladder does not contract, because food is the stimulus for cholecystokinin to be released and for the gallbladder to contract. So you don't eat. Your parenteral means your food is coming through the IV, or your patient has pregnancy, because pregnancy, it has something to do with the hormones of pregnancy. The decreased motility of the gallstones, or decreased motility of the gallbladder, because you have decreased cholecystokinin, and you then have a patient prone to cholesterol stone formation. Now, remember that somatostatin is a potent gastric peptide inhibitor. So it inhibits cholecystokinin and promotes stone formation. Okay, so these are the three factors: supersaturated, too much bile, that is supersaturated with cholesterol, clear crystals to form stones, and last, of course, gallbladder motility. So the bile salts, the normal concentration is before you. 97% are bile salts, and only about 4% is cholesterol. And there are phospholipids along with it. Now, on the right side is actually what happens in a patient with the enterohepatic. So enterohepatic, babalik sa liver. So primary bile salts are synthesized in the liver, then conjugated and secreted in the bile, reabsorbed in the terminal ileum, and then goes back to the portal vein and back to the liver, back to the gallbladder. So 5% only is lost in the feces, and bile acid pool is about 2 to 4 grams in cycles of 6 to 10, decreased pool, decreased cholesterol solubility, and a lithogenic bile. So all of this points to enterohepatic circulation. The mechanisms that are linked to production of salts, we have too much cholesterol in the body, whether it's obesity or diet, too much lechon or too much adobo, pork adobo, you have increase of this reductase, you increase now your transporter activity. Now, there are mutations that are related, the ABCB4, which is decrease in phospholipid secretion, and therefore your lecithin is decreased, and it pours now an unstable Michelle's. There is decrease in bile acid secretion, the decrease activity, the limited step, therefore you decrease your bile salts. And as I mentioned, those with decreased cholecystokinin responsiveness due to somatostatin, which is a potent gastric peptide inhibitor, patients who have pregnancy, patients who fast, or spinal cord injury. These are all related to decreased gallbladder. So in other hands, you have a bile pigment, excess of bilirubin. Wait, okay, excess of bilirubin. Bile pigment stones, bilirubin unconjugated, forms in sterile bile with gallbladder, and it is due to chronic hemolysis, cirrhosis, ineffective erythropoiesis, patients with total parenteral nutrition, and ileal disease because of the enterohepatic circulation, which does not work in a patient with gallstones. So on the right side of your screen, these are patients who have brown pigments. These are those due to infection by bacterial blood disease. Deconjugates bilirubin, releases this plus calcium, and then forms calcium bilirubinate, which then produces now more, removes the lecithin, then fatty acid soaps, and produces now a combined calcium bilirubinate. Now, what is the difference? Well, this is made of calcium. This is a hard stone. It's just like the bones. This one is also hard because it is made up of um, chronic hemolysis and all of this that are linked because it is actually linked also to calcium. But cholesterol crystals and softness can be dissolved if given the right timing and therefore are prone to patients who develop other pathologies that are related to it. Now you have the 5 Fs. What are the risk factors? Oh, remember the 5 Fs: fat, female, 40, fair, and of course, fertile. Okay. So you have fat, self-explanatory. Estrogen increases cholesterol, decreases bile salt. In pregnancy, sorry, 1 minute. In pregnancy, you can have increased estrogen, progesterone, so estrogen is higher. You have decreased motility. 40, you have cholesterol saturation, and fair, so genetic predisposition. So the 5 Fs of risk factors. There are other risk factors like metabolic, type 2 diabetes, hypertriglyceridemia, syndrome, loss of drugs, contraceptives, fibrates, ceftriaxone, octreotide, decreased motility, and GI symptoms like prolonged fasting and TPN in patients with spinal cord injury. Now, having said that, there are other pathologies that have linked with it. The natural history is that you have a gallstones, remains silent, no problem. Then through time, you develop now a symptomatic, lumalaki yan, no? So 80% is then you develop some um, moves, no? So 20 to 30% of this will become chronic and it becomes symptomatic and biliary colic. You have a stone that is impacted in the cystic duct, producing cholecystitis. And then you have persistent inflammation. You then have, there's still bile production. Then you develop empyema, abscess, gangrene, perforation. Then this is now linked to either choledocholithiasis, common bile duct degradation, and gallstones. The course that you have patients with gallstone is linked to cholesterol crystals. So there is precipitation of that 20 to 40% of pregnant women and 50% of patients on TPN. May resolve spontaneously to frank gallstones and detected in ultrasound that produce now acoustic shadowing. So step 1, cholesterol crystal saturation, linked to weight loss, the treatment or prevention treatment is actually the different steps that you have. So one is you decrease your gallstones that is seen, cholesterols that is seen in, you have to lose weight, no? So this is actually linked to that. You have a patient with low fat and high fiber, statins decreases cholesterol synthesis, udcacid, which is actually a replacement, secondary bile salts that actually replaces the hydrophobic bile salts, increasing now solubility. Crystal formation, again, the role of C is a drug that dissolves the stones. So inhibits nucleation, NSAIDs actually decrease prostaglandin mucin secretion, aspirin, and of course, on the last is you need to have regular meals because as I mentioned, if you don't eat, it does not produce contraction, so it stagnates. And avoid prolonged fasting. TPNs are actually linked to gallstones, UDCA during rapid weight loss, and of course, the exercise can improve gallbladder motility. So the key message in gallstones is three types: cholesterol, black stones, pigment stones. Most of these patients will have problems related to brown, which is related to fat infection. Cholesterol needs three conditions: bile saturation, nucleation, and GI motility. The black stones are hemolysis, and lastly, 80% are asymptomatic with UDCA for dissolutions. Okay, let's start with cholecystitis. Okay, can you see now? Okay, gallstones typically are maintained inside the bile, and once this contracts because of food, then these stones go out. The moment it goes out, it becomes that's where the problem lies. So you have cholecystitis when the gallstones actually predominate in the cystic duct. You have a patient who's lucky enough that the gallstones traveled all the way to the common bile duct. You have now, and this is actually an emergency. Okay? So, in such a scenario, you now have a patient who develops signs and symptoms related to biliary colic. So, the epidemiological strategy is before you. So 10 to 15% of ultrasound of adults have gallstones. They are non-modifiable: female, sex, age, genetics. About 1 million undiagnosed case. You have 2 to 5 years and 90% of this actually will develop stones or cholecystitis. So modifiable risk, if this is present, you can actually tell your patient, you better be careful, you don't eat fat. This all adds up to modifiable risk factors. Now, you have now the cause of cholecystitis. This then tells us that there are some patients who actually develop those related to such. And this is actually increased cholesterol, decreased bile salt, supersaturation. You have gallstones, obstruction, and therefore you have inflammatory cascade, which is ischemia, because the bile cannot come out, it becomes inflamed, the gallstones become inflamed, edematous, and you develop acute cholecystitis. There is 5 to 10% of patients who does not develops all of this, but there's no stone. These are critically ill patients, so this is a calculus, but you develop still inflammation of the gallbladder. Now, this then produces symptoms of right upper quadrant pain, patients with low fever, especially if there's obstruction and nausea and vomiting. On the right side, as I mentioned, there is right upper quadrant pain. There is gallbladder palpability because it's big, and the patients with fever and peritoneal signs. Now, there is a severity that's being used, the Tokyo classification, which actually guides on the guidelines of cholecystitis. Grade 1 is mild, grade 2 is moderate. You have WBC of right and right upper quadrant of 18,000 to 72 hours and marked local inflammation. In severe, we have other organ dysfunction, which can actually cause patients the problem. Now, there are some complications related to gallstones. Empyema. First, of course, as I mentioned, you develop gallstones, you develop now obstruction. Therefore, the stones are actually impacted. You develop now abscess. You have a gangrenous cholecystitis. You have a gallbladder that's so huge that it's tried is when your gallbladder goes around and impedes the cystic duct, you have now obstructive jaundice. Cholecystitis does not have jaundice. So that's a peculiar characteristic. Cholecystoenteric fistula, this patient's gallstone went into the gallbladder, duodenum, and traverses through the colon, and of course, septic complications. You have also patients with chronic cholecystitis, those which results from episodic biliary colic or subclinical inflammation. Chronic means it has been there for a long time. So you have chronic inflammatory sign, which is mucosal herniations, fibrosis, metaplasia, and of course, increased motility and or porcelain gallbladder. Now you have a patient on the right side. On the left side, you can see, or on the computer's right side, you can see recurrent episodic right upper pain, often post-fatty, patients with duration for 30 to 60 minutes, to symptomatic and fractionated dyspepsia. There are diagnostic workup you use because it's infection. You use a CRP and WBC. These are markers of severity of infection. Bilirubin to assess whether the stones really obstruct. As I mentioned, in patients with cholecystitis, do not have jaundice, not unless you form a Merit cyst that you actually prevent the bile from flowing through back and forth. You develop now relationship with bilirubin. For time, you do the ultrasound. Ultrasound negates the presence. You do a HIDA scan, and if the patient still continues to have complications, then you need to do already pre-operative planning. Management is actually very simple. You need to undergo lap cholecystectomy. Lap cholecystectomies, you have 3 holes, but they just actually get it and let the gallbladder pass through very tiny holes. So this we are able to do in Fatima. In cholecystectomy, you can for reversibility by giving ursodeoxycholic acid, or you can have an elective cholecystectomy, or indications for cholecystectomy. Remember, symptomatic gallstones, acute cholecystitis, gallstone pancreatitis, choledocholithiasis, and gallbladder polyps. Differential diagnosis because it's in the middle, pancreatitis, GERD, pneumonia, choledocholithiasis, peptic ulcer, acute hepatitis, acute appendicitis, and of course, it's which is young women, hepatitis from PID. This is worrisome because the patient cannot recover from it. So key takeaway message is that 90% of patients have gallstones. You have Murphy's sign is diagnosed early. Severity dictates timeline, covered for the gram-negative enteric, chronic fibrosis plus loss, and don't use or don't miss out complications. Okay, are there any questions? Okay, sige. You want, okay, I will end my lecture here and then increase the lecture series next week on Tuesday. Is that okay with you? Hello?
Yes po, Doc. It's okay po.
Okay, sige. So, is there any question? You don't have a question? See you on Thursday, Tuesday, face-to-face.
Tuesday is online po, Doc.
No,
Based on school policy, alternative learning po. So this way, inside and will be online po, Doc.
so we will shift. Because they told me you're on Zoom. So I thought it is